So welcome. My name is Timothy Byars. I'm the Director of Cannabis Programs at Pacific College and the President Chief Education Officer of Radicle Health. This lecture is number 2. It's the second lecture in a series that we're doing over the course of about 4 months. And mostly the content will be around cannabis science and cannabis policy. And I'm hoping that this content will reinforce and support the material that all of you are getting in your Pacific College courses and in your Radicle Health packages and modules. So again, this is the schedule of the next 2 lectures. We'll continue to have an opportunity to meet about once a month during the next 2 months through the beginning of the summer. So today we're going to talk about a lot about cannabinoid pharmacology, which is the study of drug properties and their interaction with living organisms and viruses. So I kind of like to talk about the 3 subdisciplines of pharmacology. So there's pharmacodynamics, and I know this is review for many of you, but pharmacodynamics, the study of biochemical, physiologic, molecular effects of drugs on the body. When we're talking about pharmacodynamics, we're usually talking about things like the study of receptor binding and sensitivity, affinity, post-receptor effects, the chemical interactions that occur. Usually when we talk about pharmacodynamics, we are talking about what the drug does to the body. And then there's pharmacokinetics. So pharmacokinetics is referring to the movement of the drug into, through, and out of the body. It's going to measure the absorption, the distribution, the metabolism, and the elimination of the drug. So many of you are familiar with the acronym ADME. Again, absorption, distribution, metabolism, elimination. So pharmacokinetics is usually, when we talk about pharmacokinetics, we're usually talking about what the body does to the drug. And then lastly, pharmacogenetics. So this is the study of genetic differences that affect individual responses to drugs. We can look at genetic differences that are specific to enzymes, messengers, neurotransmitters, receptors, metabolic pathways. All of these things can impact the therapeutic effects and adverse effects that are experienced by an individual patient. I like this slide because I think it's a really simple illustration of how drugs move through the body. So in the top left, you have the box says drug release and dissolution. So however the drug is being administered, it's being basically absorbed into the body. It goes into circulation. So basically it gets into the bloodstream. It starts to circulate through tissues, and that's when we're going to have our pharmacodynamic effects, right? It's once it starts distributing through the body, it's binding to receptors, going back, through circulation, and then also at the same time, it's starting to get metabolized and then also excreted. So just sort of a simple illustration here. All right, so I'm going to start with entourage effect because I want to approach our discussion about cannabis pharmacology by beginning with this concept. And of course, all of you know this concept posits that chemical compounds in cannabis can work together to produce a synergy of benefits. And in some cases, this hypothesis suggests that the effects are actually greater than the sum of the individual components. Obviously, chemical compounds interact in our bodies. That's what chemical compounds do. But we want to look more closely at the idea of entourage effect and see how it might inform our understanding of cannabis pharmacology. So let's start with these 2 guys, Raphael Mechoulam and Shimon Ben Shabbat. So in 1998, they were working in the lab together. They discovered that 2 esters, and these esters had no binding affinity to cannabinoid receptors, but they did significantly potentiate the binding of 2-AG, so our endogenous cannabinoid, at the CB1 and CB2 receptors. So don't worry so much about whether you know what an ester is. It's a class of organic compound that they react with water, and they produce alcohols, and they produce acids. But the takeaway here is that Meshulam and Ben Shabbat, they referred to this relationship as an entourage effect. And they noted that it was also observed with esters in combination of some synthetic cannabinoids. So all of the HU synthetic cannabinoids, HU stands for Hebrew University. Those were created by Meshulam and other members of his team in his lab. So they found that this same effect was happening with some synthetic cannabinoids. They published a paper, and they included a suggestion that researchers investigate the effect of active components in the presence of entourage compounds to potentially observe the effects of these compounds as they might occur in nature, because they were working, in basically in a petri dish. So since then, the cannabis industry has adopted this language to suggest that chemical compounds in cannabis can work together to produce a synergy of benefits, and this synergy is now referred to entourage effect. So there is evidence, there's further evidence of entourage effect in the medical literature that support this concept. 2015, there was an Israeli study that demonstrated that whole plant high CBD cannabis was, they called it superior over synthetic CBD for the treatment of inflammatory conditions. They had reviewed all of the available data, and they determined that the administration of pure isolated CBD had no therapeutic effect beyond a certain dose threshold. And conversely, the anti-inflammatory and anti-pain response of whole plant CBD continued to increase with dose. So they suggested that this makes whole plant CBD more ideal for clinical use. There's another study in 2009. This study was a little bit more broad, but they wanted to study the long-standing and successful use of herbal drug combinations in traditional medicine and figure out why the pharmacological and therapeutic superiority of many of them in comparison to isolated single constituents. Now, the study noted that whole plant extracts can affect multiple targets in the body, can improve the absorption of the active ingredients, can overcome bacterial defenses, and can minimize adverse side effects. An irony here, and one of you actually pointed this out in a discussion forum post, I think maybe last week. In the Western medicine model, substances that bind to multiple targets are often referred to as dirty drugs. There's a negative connotation that's associated with these compounds, but here we have a study that's suggesting that these sort of herbal approaches to therapeutics can sometimes have a lot of benefits over the more traditional Western medicine model of a single isolated component. And here's our friend, Ethan Rousseau. He and Jeffrey Guy in 2005 suggested that CBD can enhance the medical benefits of THC and reduce the adverse effects. Again, another suggestion of entourage. Rousseau pointed to data that suggested that 10 milligrams of THC will typically cause acute psychosis in about 40% of people who take that amount. And then he pointed to the clinical trials that were conducted by GW Pharmaceuticals when they were developing Sativex. Sativex is an oral mucosal spray. It has equal parts THC and CBD. And during their clinical trials, 48 milligrams of THC was administered with equal amounts of CBD, and it produced acute psychosis in only 4 patients out of 250 exposures, so about 1.6%. So again, suggesting that there's this effect that's happening when you have multiple compounds. And then more recently, in 2016, there was a private company that reported they had suggested that they found 8 terpenes and 3 new cannabinoids that increased the potency and effects of THC at CB1. This was really interesting research when it came out, but I haven't seen any published data since the original press release in 2016, and I can't seem to find any evidence that they ever really pursued this. But I'm assuming that the results will likely be demonstrated, if this is the case, through positive allosteric modulation. But again, just another example of some data that may support entourage effect. So when we're looking at this concept, we really want to talk about what's happening at the pharmacological level here. Within the context of entourage, there are actually three distinct categories that describe how compounds can interact. And these are examples that were described really wonderfully on Michael Tagan's website, Prof of Pod. I don't think it's up anymore, which is really a shame. I've reached out to Michael to see what their plans are, what the content. I'm hoping that they will either, republish it or maybe, combine that information into some other deliverable. But when it was up, it was really fantastic work. So he's describing these three distinct categories of how chemical compounds are reacting. So the first one is pharmacokinetic interactions, and these are interactions that occur when a molecule impacts the concentrations of a second molecule, either in the brain or in the bloodstream. So during a pharmacokinetic interaction, you have one molecule that can affect some process of the absorption or the distribution or metabolism or excretion of the second molecule. So, for example, there's some evidence in animal models that administering CBD before THC, about 20 minutes prior, 20 to 30 minutes, can actually increase the levels of THC in the blood and the brain. There's no similar effect that's demonstrated when CBD is administered concurrently with THC. So CYP2C9 is the primary enzyme responsible for the metabolism of about 100 therapeutic drugs, things like blood thinners and non-steroidal anti-inflammatory drugs. This same enzyme metabolizes both THC and CBD, and it's the primary enzyme for the metabolism of THC into 11-hydroxy. So there's research that suggests that CBD is actually a really potent inhibitor of CYP2C9 activity. And inhibition, when we talk about enzyme inhibition, it really happens almost instantaneously. So it can immediately exaggerate the effects of any subsequently administered drugs. So if you administer CBD prior to THC, it's possible that a larger amount of THC is actually available to the bloodstream, and that THC will remain in the body for a longer period of time, because CBD is it's inhibiting that enzyme. So the enzyme isn't working well. It's not metabolizing THC. More THC is making it into the bloodstream, and that effect is always going to be. It's going to depend on the dose and on the cannabinoid ratio and on the timing. Again, the study had, I think it was 20 or 30 minutes prior to administration. So let me just stop a minute before I move on to the second two, because I want to make sure that we all understand the differences between inhibiting an enzyme and potentiating an enzyme. So when we inhibit an enzyme, the enzyme doesn't work as well. It doesn't metabolize a drug. There's more drug in the bloodstream, and the risk is that there can be adverse effects because the patient can experience what they might feel like if they took too much. If we potentiate an enzyme, that means we're making the enzyme work more effectively. There's more of it. So whatever drug it's metabolizing, there will be less of that drug in the bloodstream. So a patient can feel like they haven't taken enough. They're not getting their standard dose, and it's not working as well. All right. The second type of interaction is an indirect pharmacodynamic interaction. And this can occur when a molecule modulates a second molecule, but by binding to a different receptor than the first molecule. So, for example, CBD has non-cannabinoid receptor mechanisms that will also likely impact the pharmacodynamic effects of THC. And I love this illustration here because it really does give us a sense of how promiscuous CBD is and why it doesn't really bind all that well to either of the canonical cannabinoid receptors, but it does all of this other stuff. And so the effects of CBD are probably mediated through through these other mechanisms. I know that there are starting to be some questions in the chat, and I'll address them at the end of the hour. So please keep putting them in there. Okay, so CBD is a potent agonist at some of the 5-HT1A serotonin receptors. And agonists at these receptors can help relieve anxiety. So we also know that CBD can lower blood pressure. So if you have an overactivation of the CB1 receptor, let's imagine that you consumed too much THC and it's producing anxiety. The activation of these serotonin receptors, the 5-HT1A receptors, might help mitigate those effects. The anxiolytic effects of CBD or any substance that you take, whether that's caryophyllene or limonene or linalool, any compound that's traditionally used to mitigate anxiety, might be mediated through this type of interaction at the serotonin receptor. All right, the third type of interaction is a direct pharmacodynamic interaction. And this occurs when a molecule modulates the effects of a second molecule, but it binds to the same receptor. So during this type of interaction, two molecules are both attaching to the same receptor, but not necessarily to the same receptor site. Recall that there are two binding sites. There are the main orthosteric binding site, and there's the secondary allosteric binding site. So they're actually, this third type, direct pharmacodynamic interaction, there are actually three subcategories of this. And they are classified as additive, synergistic, and antagonistic. So let's look at each one. So additive interactions occur when two molecules act on the same receptor in the same manner. So for example, they're both agonists. THC, CBD, both negative allosteric modulators at the 5-HT3A serotonin receptor. So the effect here is simply cumulative, right? They're both doing the same thing. There's a cumulative effect because they're just more of the same kind of substance having the same kind of effect. Anytime I mention the 5-HT3A serotonin receptor, and I say that THC and CBD are both negative allosteric modulators, I also like to point out that alcohol is a positive allosteric modulator at 5-HT3A, and activation of this serotonin receptor can actually cause nausea. So maybe that's one reason why if we drink too much alcohol, we get nauseous. The second type, synergistic interactions. So this can occur when a combination of molecules has an effect that seems to be greater than a simple additive or cumulative effect of the contributing molecules. And I want to propose that when most people, especially in the cannabis space, think of entourage effect, they're thinking of this kind of combination where they have these chemical compounds in cannabis, they're working together, and they're producing the synergy of benefits that's actually greater than the sum of the parts of the chemicals. And then the last one is antagonistic interactions. So these occur when a molecule inhibits the effects of the second molecule, and antagonistic interactions can occur if, for example, one molecule is an agonist at a receptor and the second one is an antagonist at the same receptor. So in this scenario, the two molecules would compete for the same receptor sites and they would have different impacts on the cell to which they're binding. Antagonistic interactions can also occur if one molecule is an agonist and the second is a negative allosteric modulator. Okay. So let's talk briefly about pharmacokinetics. Remember that pharmacokinetics refers to the movement of the drug into, through, and out of the body. It measures absorption, bioavailability, distribution, metabolism, excretion. And again, it's, when we talk about pharmacokinetics, we're talking about what the body does to the drug. We're really only going to cover metabolism and very briefly today, just for lack of time. But recall that when ingested, cannabinoids are mostly metabolized in the liver if you eat them, the cannabinoids, and they're mostly metabolized by the cytochrome P450 enzymes. So the CYPs are a family of enzymes that metabolize drugs, and they They modify, they detoxify, they remove drugs from the body. And it's a large family of enzymes, but there's a small group of maybe 5 or 7 that really metabolize most drugs that we take. And most of them are in the CYP family. So THC is mostly metabolized by CYP2C9 and CYP3A4. CYP3A4 is actually one of those enzymes that metabolizes a large number of pharmaceutical drugs. THC, when it is metabolized, it's converted into 11-hydroxy THC, and then after that, it's converted into 11-carboxy THC. In fact, I believe that when you take a drug test, if you're taking a urine test, it's the 11-carboxy that they're testing for, because that's one of the last metabolites before you actually excrete it. Metabolism of THC can occur outside of the liver also, obviously. We don't always eat cannabis. So it can occur in tissues that also express CYP enzymes. It can occur in the small intestine. It can also occur in the brain. And then, of course, we have some long-term storage of THC that occurs in our body fat. CBD is metabolized also in the liver by CYP enzymes, mostly by CYP2C19 and also CYP3A4. And when CBD is metabolized, it's converted into 7-hydroxycannabidiol. We talked a little bit about fatty acid amide hydrolase during the last lecture. Just remember that this is the enzyme that metabolizes anandamide. There's a little bit of research, it's older research that suggests, it's in animal models. It suggests that CBD can potentiate the effects of anandamide, and there was speculation that it was because it was inhibiting Pha. But that hasn't really borne out in clinical trials. There's a new theory that if cannabinoids are potentiating our endogenous cannabinoids, it's likely because they're competitively binding to fatty acid binding proteins that actually carry anandamide and 2-AG into the cell for metabolism. So because there's that competitive binding at these sites, anandamide, sometimes anandamide doesn't win that competition, and so it allows the compound to stay out in the bloodstream and do its work a little bit longer. All right, so complete elimination of cannabinoid metabolites. It'll occur over several days. There's a slow rediffusion of cannabinoids that occurs through body fat and other tissues. So we see about 20 to 35% of these metabolites eliminated in urine, about 65 to 80% eliminated in feces, and we have about 90% that's excreted in 5 days. Residual levels of cannabinoids remain in the body for kind of a long time in long-term users. The half-life of THC for infrequent users is about 1.3 days, but it can be 5 to 13 days for frequent users. So, sometimes if somebody's worried about taking, a drug test because they've used cannabinoids and they're a long-term user, they may have to abstain for about 30 days before it's completely eliminated from their system. After inhalation, the metabolite carboxy THC can actually be detectable in your plasma for about a week. All right, so I want to move back into discussion about pharmacodynamics and talk more about receptors. I know we talked at length about generally about receptors in our first lecture, but I want to go back to it and start looking at some other types of receptors that are involved in or at least influenced by the ECS. So obviously, when cannabis is consumed, cannabinoids that are produced by the plant, they're binding to receptor sites throughout the body and the brain. We know that we have multiple receptors that are modulated by the endocannabinoid system. The 2 endocannabinoid receptors are referred to as CB1 and CB2. And we talked about this during our last lecture. The effect of the cannabinoid depends on the receptor to where it binds, right? So if you have THC binding to CB1 receptors in the brain, It's going to produce a psychoactive effect. If you have THC binding to CB2 receptors located throughout the body, it's going to hopefully produce an anti-inflammatory effect. And so we know that specific cannabinoids can produce unique therapeutic effects depending on the receptor to which they're binding. So again, we've kind of talked about CB1 receptors. I don't want to spend a whole lot of time on the cannabinoid receptors tonight, but these are ubiquitous in the body. The receptors are actually concentrated in regions associated with the behaviors that the receptors influence. So CB1 receptors, for example, that are helping to regulate appetite. Usually that's through receptors in the hypothalamus. If it's influencing memory and emotional processing, that's likely through receptors in the amygdala. Those that are mediating sensation to pains, probably happening through receptors that are on nerve endings. And again, somebody asked this in the chat, I think, but 11-hydroxy THC interacts much more efficiently than THC at CB1 receptors, so the effect can feel like it's more potent. It's not quite the right word. We're really talking about binding affinity and efficacy, but 11-hydroxy THC does have higher binding affinity and greater efficacy at CB1 than THC does. And this is a list of the things that CB1 receptor activation helps to mediate. So there's a long list of therapeutic benefits that are well documented. And again, there are antagonists and inverse agonists that have been studied at the CB1 receptor, mostly in the treatment of obesity as an adjunct to diet and exercise, but also for things like metabolic syndrome, liver fibrosis, nicotine addiction. And these studies actually demonstrated that receptor antagonists can help bring raised endocannabinoid levels back into a healthy range. CB2 receptors, again, we talked about these a little bit last lecture. A couple of important facets to remember are, one, that the number of available CB2 receptors increases significantly during inflammation. So, and that's probably because there are a lot of CB2 receptors on the types of cells that are involved when we have an immune response. And then secondly, CB2 receptor activation doesn't really produce the type of psychoactivity that we tend to associate with CB1 receptor activation. I don't like to say that CBD is, or CB2 activation is non-psychoactive, because depending on the effect, it can be psychoactive, just not in the same way that we associate with CB1. And this is the list of things that CB2 receptor activation helps to mediate. Again, these are well documented in the literature. I want to talk a little bit, before we go on to some other receptors, I want to talk a little bit about beta-caryophyllene, or BCP. Very common terpene in cannabis. It's the one that smells like black pepper. It's the one that drug dogs are trained to detect in airports. Unlike other terpenes, beta-caryophyllene actually exhibits ligand-like properties, and it's an agonist at the CB2 receptor, and it's demonstrated affinity with other receptors that also influence neuropathic pain and neurodegenerative disease. BCP exhibits such potent anti-inflammatory properties that there are some researchers that think it should be classified as a cannabinoid rather than as a terpene. And in one study, it was actually, as an anti-inflammatory, it was more effective than some synthetic cannabinoids. So we see that it can exhibit potent anti-inflammatory properties in multiple models of human disease, as well as antispasmodic properties. It has antidepressant, anxiolytic properties, and anti-addictive properties. Yes, Megan's mentioning that the DEA might outlaw black pepper. Don't carry your black pepper through the airport, whatever you do. All right, so let's move on and talk about some other types of receptors, some non-cannabinoid receptors. And we're going to start with the orphan receptors. So in biochemistry, Orphan receptors refer to receptors for which no endogenous ligand has been identified. So in other words, researchers, they discovered the receptor before they really understood what molecules that we make inside of our bodies bind to the receptor. So when an orphan receptor is detected, they're typically named with the prefix GPR, and that just stands for G protein receptor. And then it's followed by a number. I don't know for sure, I couldn't find this out, but I think that they're sequential, but I don't know for sure. But there are just slightly over 100 existing orphan G protein coupled receptors, orphan receptors. And when researchers do find an endogenous ligand that binds to the receptor, the orphan receptor is considered adopted. And there are two important adopted GPR receptors that are modulated by the endocannabinoid system, and those are GPR18 and GPR55. And some researchers, some people in the cannabis space, actually like to refer to these as novel cannabinoid receptors. So let's start with GPR18. These you'll see these written in the literature sometimes as anarachidonyl glycine receptors, or sometimes you'll see it written as capital NAG lowercase ly. So that's a GPR18 receptor. They're located throughout the body. They're in the gastrointestinal tract. They're in the brain. They're in your white blood cells, lymph nodes. This receptor is activated by a compound called N-arachidonyl glycine, and that compound is actually created when anandamide is metabolized. It's a metabolite of anandamide, so that's sort of interesting. The expression of GPR18 receptors in white blood cells suggests that these receptors influence immune system activity, and the activation of these receptors is probably helps to reduce inflammation. There's also evidence that activation of GPR18 lowers intraocular pressure in the eye. And there's a rodent study where researchers noted that THC also lowers intraocular pressure by activating both CB1 and GPR18. The one interesting facet about that study is that there were gender differences. Those effects were much more pronounced in the male mice and much less pronounced in the female mice. We also think that GPR18 might reduce the transmission of pain signals, and that would help alleviate pain. Expression of GPR receptors in the brain, especially in microglial cells, suggests that the activation of GPR18 might help treat neurodegenerative disorders. So microglia cells are the brain's immune cells. They help protect the brain against injury and disease. They remove toxic agents from dead cells. In neurodegenerative disorders, things like Alzheimer's disease, these microglial cells can actually become hyperactivated, and they can promote neuroinflammation. So the inflammation is part of what promotes the toxic protein deposits of amyloid plaques. And we think that the modulation of GPR18 might contribute to the management of that type of neuroinflammation. All right, GPR55. So these receptors are located in the brain, also in the gastrointestinal tract, in the pancreas, in the adipose tissue, so in our body fat. There is a endogenous ligand that binds to GPR55. You can read its name on the slide. I'm not going to attempt that one. GPR55 receptor activation has been associated with things like cancer cell proliferation and disease progression. Also inflammation and certain types of pain. So in a study where mice were genetically bred without these receptors, those mice actually demonstrated lower levels of inflammation, lower levels of inflammation-based pain, and lower levels of neuropathic pain after nerve constriction. It's a very terrible test that people do on animals. But GPR activation, not a good thing, at least later in life. So the study of this receptor seems to be uniquely difficult for some reason. But there is some data that suggests that CBD is an antagonist of GPR55. And if CBD does inhibit GPR55 signaling, again, it's this, it's a non-cannabinoid receptor mechanism to explain some of the therapeutic benefits of CBD. So, maybe CBD reduces seizures by blocking the activity of GPR55 in the hippocampus. Inhibition of GPR55 might also explain some of CBD's anti-tumor effects in things like colorectal cancer, and breast cancer, pancreatic cancer, and brain cancer. And then finally, the modulation of these receptors might also explain how CBD can reduce gastrointestinal inflammation in conditions like inflammatory bowel and Crohn's and ulcerative colitis. This is this type of activation in our bodies is it's an example of a receptor activation that produces adverse effects. And it kind of begs the question, like, why would we have these things in our bodies? Like, what, from an evolutionary perspective, how does that serve us to have a receptor that, when activated, is actually detrimental to our health? And I don't know the answer to this, but I can speculate that one suggestion has to do with a concept called antagonistic pleiotropy. And this is an idea that that we have functions in our bodies that have multiple effects. And some of these effects, some of these receptor activations or the mannerisms of our genes, they might actually serve to facilitate reproduction early in life. But later in life, they go on to cause problems. Recall that we've only been living into old age for a very short period of time during our evolution. And so, when we lived to the ripe old age of 40, probably some of these adverse effects never occurred. These were things that were helping us reproduce. If nature has a bucket list, it's to reproduce, right? That's it. And so probably what's happening here is that these receptors have some function that helps facilitate reproduction, but then once that reproductive phase is over with and we move on into our older phases of life, they're no longer really serving us, and they can sometimes have adverse effects when they're activated. All right, let's talk about 5-HT receptors. So these are receptors typically activated by the neurotransmitter serotonin. It's kind of a weird abbreviation, but 5-HT stands for 5-hydroxytryptamine. And these receptors are collectively known as the serotonin receptors. And they're hugely important. They influence aggression, anxiety, appetite, cognition, learning, memory, mood, nausea, sleep, our body temperature. They are targets of hallucinogens. They're targets of lots of different prescription medications, so antidepressants, antipsychotics, anti-migraines, antiemetics. And there's a huge number of them. There are 7 distinct families of the serotonin receptors. All of the families have subfamilies. We're only going to really briefly talk about 2, and not even 2 families, but 2 subfamilies. The first one are the 5-HT1A receptors, and this is actually the most widespread of the serotonin receptors. They're located in very high densities in our central nervous system. Receptor activation can decrease blood pressure, it can decrease heart rate, decrease body temperature. These receptors, when they're activated, they can also help relieve anxiety and depression and nausea and pain. And there's some speculation that receptor activation can also help improve symptoms associated with schizophrenia and Parkinson's. So, these are receptors that are calming us down. They're anxiolytic when they're activated. There's also some research in animal models that suggest that these receptors can help mitigate liver damage. And again, the animal model research is also pointing to the receptor activation as as being anxiolytic. They help with depression, they help with pain, they help reduce nausea. CBD is a full agonist. It's a very potent agonist at 5-HT1A. And again, this is possibly why CBD is helping with things like nausea and vomiting and seizures and pain and mood disorders. And I think I mentioned earlier, THC and CBD are both potent negative allosteric modulators of 5-HT3A. Do I want to move on to that? No. Yeah, so 5-HT3A receptors, these are receptors that are actually associated with nausea and vomiting and seizures and pain. And THC and CBD are potent negative allosteric modulators. So it's probably a reason why, in combination with CBD being an agonist at 5-HT1A, given that it's a negative allosteric modulator at 5-HT3A, it's probably the reason why these cannabinoids are really effective at treating chemotherapy-induced nausea and vomiting. All right, let's talk about dopamine receptors. So these are G protein-coupled receptors. They're concentrated in the central nervous system. The neurotransmitter dopamine is the endogenous ligand for dopamine receptors. Dopamine is integral to the brain's reward system, and it's released typically in response to pleasurable stimuli. So we produce dopamine when we eat, when we sleep, when we procreate, when we exercise, and the activation of these receptors can affect motivation, it can affect pleasure, cognition, memory, and also learning. So when we have dysfunction of dopamine receptor signaling, it can contribute to neuropsychotic and neurodegenerative disorders. So things like Parkinson's, but also drug addiction and compulsive behavior, ADHD, schizophrenia. So dopamine receptors are commonly prescription drug targets. The relation between cannabinoids and dopamine release is complex. There's not a one-to-one relationship here. In fact, most cannabinoids don't directly bind to dopamine receptors, but some cannabinoids do seem to influence dopamine release. And certainly the endocannabinoid system modulates the release of dopamine. There's some research that suggests that cannabinoid receptor modulation can also impact dopamine function. So consequently, cannabinoid receptor agonists like THC can influence dopamine differently than cannabinoids with little affinity for CB1 or CB2. So the effects of THC on dopamine suggest a biphasic effect. What we see is that short-term acute use of THC seems to increase dopamine release, right? We use cannabis, feel pretty good. But long-term chronic use, heavy use seems to inhibit dopamine release. And when we're really talking about dopamine receptors within the context of cannabinoids, at least, we're really talking about the dopamine receptor D2, or sometimes you see it written as D2R, or dopamine 2 receptor. And this is the D2R is the primary target for most antipsychotic drugs. So again, D2R commonly used, drugs that are acting at D2R, they're commonly used to alleviate symptoms that are produced by Parkinson's, schizophrenia, depression. And antipsychotics are often prescribed for these diseases because they're potent partial agonists at D2R, and they increase dopamine signaling. Right? That's what Parkinson's is. It's a lack of dopamine signaling. So CBD is also a potent partial agonist at D2R. We should note though, and this possibly is the reason why we can have some adverse effects when we take too much CBD. D2R agonists can produce adverse effects, and those effects can include GI distress, things like abdominal pain and diarrhea, but also things like dizziness and headache and fatigue. And these are side effects that are sometimes attributed to CBD. All right, adenosine receptors. So again, also G protein coupled receptors. Activated by the neurotransmitter adenosine. So adenosine receptor activation causes drowsiness, it causes memory impairment. We all know what the most common adenosine receptor antagonist is. It's caffeine. And caffeine does its thing by inhibiting adenosine signaling, and that's why it's able to produce stimulating effects. THC and CBD don't actually bind directly to adenosine receptors, but they can influence adenosine receptor signaling. So both THC and we think high doses of CBD can potentially inhibit adenosine uptake. So we talked a little bit about reuptake in our last lecture. Remember that when a neurotransmitter is released, it's metabolized. Sometimes it's metabolized in the interstitial fluid in between neurons. Sometimes it's actually brought back into the cell that released it. Sometimes it's brought into a different cell in order to get metabolized. But that process of being brought back into the cell is called reuptake. We think what's happening is that THC and CBD are inhibiting that reuptake, and that allows more adenosine to remain active longer and to activate more receptors and make us more sleepy. So we think that cannabinoids inhibit the reabsorption of adenosine in the same way that it might be potentiating anandamide, which is by binding to that glycoprotein drug transporter that carries adenosine back into the cell where it's kind of recycled. Adenosine agonists, so things that are helping to activate these receptors, have anti-inflammatory effects. And adenosine uptake is actually the primary mechanism that terminates adenosine signaling. So instead of having like some other enzyme that's metabolizing it, most of it is just being brought back up into the cell. And that's how adenosine signaling is terminated. Well established that cannabinoids have anti-inflammatory effects, and some of these effects are mediated by CB2. But we know that CBD, it weakly binds to CB2, if at all. So by inhibiting adenosine uptake, CBD enhances endogenous adenosine signaling. And again, it suggests a non-cannabinoid receptor mechanism by which CBD can decrease inflammation. I want to talk about this because there's a little debate about whether high doses of CBD can be sedating. So in clinical trials of Epidiolex, sedation was listed as one of the most common side effects. Now, this effect might be related to amplified adenosine. You know, we have high doses of CBD, right? That's facilitating adenosine signaling. It's preventing the reuptake of adenosine. And so maybe that's what's contributing to the fatigue. Our friend, Dr. Ethan Rousseau, suggests that CBD, even if it's in its pure form, even if it's administered in very high doses, is not a sedative. He's very firm on this. He suggests that we might have these kinds of side effects, and if we do, it's related to polypharmacy. So he's talking about how CBD is potentially potentiating other drugs that also possibly produce sedation as a side effect. Remember that, you know, these patients who were taking Epidiolex, they are also taking other drugs to help treat epilepsy. So maybe CBD was either inhibiting or potentiating the enzymes that influence those drugs. And that's why Dr. Rousseau is suggesting that that the patients in the clinical trials for Epidiolex were having fatigue. He also suggests that you know, cannabis products that have high CBD might be sedating if they have specific terpenes in them, things like linalool and myrcene that help us relax, and that have typically sedating effects. I did reach out to Dr. Rousseau and ask him about adenosine reuptake inhibition, but he didn't get back to me. So, all right, glycine receptors. Glycine receptors inhibit nerve activation, which tend to regulate pain and inflammation. So anandamide, THC, CBD, all positive allosteric modulators of glycine receptors. So remember, glycine is one of the major inhibitory neurotransmitters, and you know, lots of glycine receptors in the brainstem and in the spinal cord. There is a study that in mice that demonstrated that CBD can potentiate glycine receptors. again, helping to inhibit transmission of pain signals, and this might also help treat chronic pain. And then the other major inhibitory neurotransmitter is, of course, GABA. GABA receptors are a class of receptors that respond to the neurotransmitter gamma aminobutyric acid. There are two families of GABA. There's GABA A and GABA B. Usually when we're talking about cannabinoids, mostly we're talking about the GABA A family. But this is the family of receptors that mediate the effects of things like barbiturates and benzos and alcohol. So receptor activation produces anxiolytic effects. It can be anticonvulsant, amnesic, sedative, hypnotic, euphoric, and then also it can have muscle relaxing effects. CBD, positive allosteric modulator of GABA A, and this is another mechanism that might help explain CBD's anti-epileptic and anxiolytic properties. THC can also influence GABA signaling by inhibiting the uptake of GABA. There is some very old research from the 70s that also suggests that CBG can inhibit GABA uptake even more effectively than THC. So we talked a lot about how cannabinoids are inhibitory neurotransmitters, and they might be inhibiting the release of both excitatory and inhibitory neurotransmitters. This is another way that cannabinoids can influence GABA signaling, by influencing the signaling itself, not through DSI, but also through direct influence. All right, the TRP channels. So these are transient receptor potential channels, and they're really mediating temperature, pressure, pain. There are tons of them. There are like 28 TRP families, and they all have subtypes. So we usually just talk about one or two, but tonight I'm just going to talk about one, and it's TRPV1. These are expressed in sensory neurons. They're also expressed in the brain, but they mediate pain and temperature sensation. And they're the receptors that are best known because they're the target of capsaicin. So that's the molecule that makes chilies taste spicy. They are activated by temperatures greater than 109 degrees Fahrenheit. So these are harmful temperatures that they're trying to try to make the body be aware of. But they're also activated by acidic conditions, again by certain compounds like capsaicin, and also by allyl isothiocyanate, and that's that pungent compound that's in mustard and wasabi. So when TRPV1 is activated, it actually produces a painful and burning sensation. It's kind of a defense mechanism for our bodies. And one thing that can be a little confusing is that a lot of cannabinoids are TRPV1 agonists. CBD, CBG, CBGV, THCV are all TRPV1 agonists. And so you might be thinking, well, why, when I rub my CBD topical on, why doesn't it cause like burning sensations? The reason is because these kinds of receptors can sometimes, they can desensitize very, very quickly. And depending on the compound, that will determine how quickly that receptor is downregulated and gets desensitized. So cannabinoids will desensitize these receptors very quickly. Even if you rub some, capsaicin on your body, it'll burn at first, but after a while, your body just kind of gets used to it. So, but cannabinoids are TRPV1 agonists, and we think through desensitization, they can also have positive effects through TRPV1, through the TRPV1 receptor. All right, it is 5:55. We're at the top of the hour. I'm not going to go over pharmacogenetics. I think I'm going to just review that in one of the office hours. I do want to have a little bit of time for comments or questions. So let me scroll really quickly through the chat. 11-hydroxy-THC has better binding affinity and more efficacy at CB1 than THC does. And it's probably one of the reasons why when we eat cannabis, it feels like it has a stronger effect than when we use cannabis through other routes of administration, right? Everyone has that story about eating an edible and consuming too much. And part of that is probably the potency of 11-hydroxy. Okay, well, I hope this was helpful. Again, this is being recorded. We will post this to our Radicle Health YouTube channel. As always, if you have any questions or concerns, please feel free to reach out to me. This is our April lecture, so we won't have another one until early May. And I think the next director's office hours is on April 24th. So I welcome you to join me. And we'll talk a little bit about pharmacogenetics. And I think we're going to talk about the carbon numbering systems also. So when you see, when you see things like delta 1 THC, and you think, well, what's that? Is that a new cannabinoid, or is that something else? We'll talk about that. We'll talk about why the numbering systems are the way that they are, and whether those of us who aren't chemists can derive any value from them. All right, everyone. Thank you for indulging me tonight. It's great to see all of you, and I hope to see you in a future office hours or lecture.